So I've been tasked with the job of talking about pulmonary endarterectomy for chronic thromboembolic pulmonary hypertension, so I've no relevant disclosures. So what I'm going to do is just present a short case of a patient with chronic thromboembolic disease who underwent pulmonary endarterectomy, and then I'll give you an overview of the surgical management of this condition. So this is a 71-year-old female who had 3 years of shortness of breath, as so frequently happens, multiple investigations, but no cause was found, but eventually it was discovered she had thromboembolic disease. Ankle edema, continuous oxygen, a preoperative right heart catheterization. There's the systemic pressure, an RA mean of 10, PA pressure 83/22 with a mean of 47, wedge pressure was 12, PVR of 11.3, CI of 1.6, transpulmonary gradient of 35. And there's her VQ scan, and you can see in the perfusion scan lots of holes there that are unmatched in the ventilation scan. And here's her preoperative echo, and you can see this left ventricle is just compressed by this very large, dilated, adversely remodeled right ventricle and the very dilated right atrium. And here's the pulmonary angiogram, and you can see that the amount of perfusion in the bases is less than in the upper lobes, and you can see this lower lobe tapers way too fast, and you can see that there as well in the left side. So she underwent a pulmonary endarterectomy. There's the specimen we removed. Here's the left side. Here's the right-sided specimen. This is the middle lobe here, and the lower lobe branches, these fibrous tails, out into the lower lobe branches, and the same on the left side. So the post-operative right heart catheterization at 6-month review, she was now asymptomatic. Systemic pressure there, RA mean 5, PA pressure 30/11, mean 19, wedge of 7. PVR down now to 2.6, CI now 2.3, and TPG of 12. And this is her echocardiogram prior to cardiopulmonary bypass. You can, at her operation, you can see this D-shaped left ventricle because of the flat septum, and this is immediately after discontinuation of cardiopulmonary bypass. So the process of reverse remodeling of this right ventricle is already underway. And at 6 months, you can see really a normal size and shape of the left ventricle, no longer compressed, and you can, I hope you can tell that right ventricle is now essentially normal size. So the process of developing chronic thromboembolic pulmonary hypertension, our sort of conventional view of it, is that there's an acute pulmonary embolus, and for a number of genetic and prothrombotic reasons, about 4% of patients will not have resolution of an acute pulmonary embolus. But as you can probably imagine, that's really an oversimplification. It's much more complicated than that, because following a pulmonary embolus, it's more than just CTEPH. So if this circle represents all patients who have had a pulmonary embolus, there are quite a large proportion who will report that they still have symptoms and reduced functional capacity. Then there are also patients that have persistent thrombi that you can see on VQ scans and CT scan. And then there are patients with some sort of measurable limitations to their cardiopulmonary function. And this group here, the Hatch group, we call the sort of post-PE syndrome. But within that, there's a very small group that actually have chronic thromboembolic pulmonary hypertension. So we're developing sort of a better understanding of the pathophysiology. So after an acute embolus, there are the usual hemodynamic perturbations, but there is probably thrombus resolution in some patients, but in others it persists because of abnormal fibrinogen, impaired fibrinolysis, and there does seem to be the need for some sort of final hit which results in situ thrombus, which is probably one of the processes that underpins this disease, and it is those patients that end up with CTEPH. Many of you will be familiar with this widely disseminated sort of time frame for the development of CTEPH from this sort of Pengo article, which is sort of quoted frequently in the literature. So this is the cumulative incidence of developing CTEPH after an index pulmonary embolus. So this is years, and it suggests that if you're going to develop chronic thromboembolic pulmonary hypertension, it's going to happen very quickly within about 2 years of having this pulmonary embolus. I really do not think that's true. And if you go into that article in some detail and look at some of the patients, let's look at this patient 5. So the time from the qualifying pulmonary embolus to CTEPH was 3 months, but yet the PA pressure had a mean of 50 with a systolic pressure of 90. That's not CTEPH developing after an acute embolus. So I think that's the time frame is much, much longer. And so patients can have CTEPH many, many, many years after developing pulmonary embolus. So you develop CTEPH because of having incomplete clot lysis and then organisation and adherence of the clot to the vessel wall. So here's the thrombus. It then propagates down the segmental and subsegmental pulmonary vessels when it's lodged in that bifurcation point. Recanalization is a very important phenomenon in this process. So here are all these channels that have sort of reopened in that thromboembolic disease. And the reason why that's important, it's important for the people doing BPA, of course, but it's also important diagnostically because when you're doing an imaging study for CTEPH, the contrast gets down in these areas of recanalization, so you always underestimate the burden of thromboembolic disease because of the imaging is less severe. So about 1 to 5% of patients with a pulmonary embolus will ultimately go on to develop CTEPH, and it's a combination of thrombophilia, abnormal clot formation, and incomplete fibrinolysis. And about 10% of patients who develop CTEPH will actually have a definable hypercoagulable disorder. Now, what we see surgically, and this is sort of an important pathology which underpins the operation, these chronic emboli are fibrous, organised bands, webs, and blind pouches. So that's a typical specimen that we would remove. This is a blind pouch with these fibrous tails going out into the segmental and subsegmental vessels. And you see on this side, this is upper lobe, this is middle lobe and lower lobe, which is really a cast of the pulmonary vasculature. David mentioned this too. This process is not just simply large vessel obstruction. There's a pulmonary vascular remodeling. But it's not as simple as it sounds, that it's just a pressure-related phenomenon. So look at the upper left-hand corner here. So that's a pulmonary arteriole with the eccentric remodeling of the vessel due to intimal hyperplasia. Now look over in the top right. So here's a bronchiole, and here's its accompanying pulmonary artery with the eccentric hypertrophy, intimal hypertrophy. But look over here, they're venules, and they're also hypertrophied. So it's a much more complicated process than just pressure. So we really don't understand what underpins the microvascular disease of CTEPH. Bronchopulmonary venous and arterial connections are an important part of this, and it's important surgically because then once you see this, you'll understand why this operation has to be performed with circulatory arrest. So there are connections formed between the vasa vasorum accompanying the vessels and also the bronchial arteries, and you get these hemangiomatous-like lesions. And you can get a tremendous shunt through the lungs, and when you open the pulmonary artery with a patient on cardiopulmonary bypass, you can get this tremendous return. So you cannot do this operation with any sort of circulation going on because you just will not be able to see down the pulmonary artery. And here's an example of the sort of extreme bronchial collaterals that can form in these patients. And we always talk about the pulmonary vascular resistance in CTEPH, but it's much more complicated than that. I'm not going to go into it, but the pulsatile, the compliance issues in CTEPH and underpinning pulmonary hypertension are probably just as important as the resistive elements. It's a much more difficult thing for us to calculate. So the survival of patients with CTEPH is poor. This is 1982 data, but it's just as relevant now. So let's follow this curve here. So this is stratified by mean pulmonary artery pressure. So if you have a mean pulmonary artery pressure with CTEPH, you're on that survival line. So your 2-year survival after diagnosis is 20%. That's the same as cancer of the stomach. So this is a very mortal process. So when BPA and medical therapy, pulmonary endarterectomy, sort of sorting each other out, this is their target. So pulmonary endarterectomy was that area here, BPA here, medical therapy in the microvasculature. Everybody was sort of staying in their lanes. But it's very different now. As far as pulmonary endarterectomy is concerned, we've got very distal. BPA have got very proximal. And of course, medical therapy is still very important. Now, we should not view this as competitive. This is complementary. I think there's a real synergy now between pulmonary endarterectomy and BPA. The interventional radiologists can deal with distal lesions that we can't get to, and then patients that have residual disease after a pulmonary endarterectomy can be dealt with, and patients that are not suitable for pulmonary endarterectomy can be dealt with BPA. So the goals of the pulmonary endarterectomy are obviously to relieve symptoms, reduce pulmonary artery pressure, remove dead space ventilation. Often patients are symptomatic with CTEPH not because of pulmonary hypertension, but because of dead space ventilation. These are the patients that wake up after a pulmonary endarterectomy and say, I can now breathe. That's because you've taken away their dead space ventilation. Obviously reverse remodel the very adversely remodeled right ventricle and interrupt the pulmonary vascular remodeling and increase, obviously, life expectancy. So the procedure of pulmonary endarterectomy is through a median stenotomy, standard cardiopulmonary bypass, and myocardial preservation. But we have to do this with circulatory arrest, so we cool these patients down to a core temperature of 20 degrees centigrade, and then circulatory arrest while we're doing the procedure. And there are a number of cerebral protection strategies that you can use. What I do is the head is encased in ice, and I use circulatory arrest for 20 minutes and then reperfuse for 10 minutes before rearresting. And that is a very, very neurologically safe protection. And then any additional procedures can be performed during cooling and rewarming, such as coronary surgery, valvular surgery, etc. Often, many of these patients are often morbidly obese, and there may be 2 hours, 3 hours of rewarming from 20 degrees. So you've got plenty of time to do any additional operation, any additional procedures. The heaviest patient that I've ever done this operation on was in the United States. That was 450 pounds, an 18-year-old, and it took about 4 hours to rewarm from 20 degrees. So our access to the right pulmonary artery can be either lateral to the superior vena cava. The technique I use is between the superior vena cava and the ascending aorta. And on the left side, from an incision made from the main pulmonary artery out onto the left pulmonary artery to the pericardial reflection. And this is the whole key to the operation. You've got to be in the right plane. So this is thromboembolic disease. Now you might think, and logically so, that the plane of dissection is at the intimal level. Well, it's not. There's the intima there. The internal elastic lamina is there, and it's sort of very fragmented because all this is very abnormal. The plane is there. It's about 1/3 of the way into the pulmonary artery. So you can see, if you're out here, then it's going to be a most inadequate endarterectomy. If you're out there, then you're just a hairbreadth away from perforating the pulmonary artery. So you've got to know exactly where you are. So
that's where we need to be. It's a trick, isn't it?
Yeah.
You turn the sound.
Yeah, there you go. That's it. That's the plane.
So that's raising the endarterectomy plane there. And then this is all this thromboembolic disease. This is very chronic, lots of calcium and atherosclerotic disease. And you have to chase it out into the segmental and subsegmental branches. And there's a fibrous tail there going out into a subsegmental branch. And you've got to separate all that and remove the specimen. And then when you've removed it all, you've got to check every segmental, subsegmental orifice to make sure you've got everything out. That's sort of a pretty good clearance there. And here's another example. This is a very fibrous pouch, and you can see all these tails that are going out into segmental branches. And you've got to chase them. You've got to know how hard to pull on them. If you pull it too hard, then you snap it off. You've got to go chasing out some very small vessels. If you don't pull hard enough, it's not going to come. So it's a sort of a very experiential operation. It's a hard operation to teach. So here's a fibrous tail, and there it's gone. And there's a residual lesion. So here's a shot looking down the right pulmonary artery. So that's in situ thrombus. And these are all holes where there should have been lobar and segmental branches. And this next shot is from the same position after the endarterectomy. And this is what you've got to see. If you don't see that, then you haven't done a proper endarterectomy. So the mortality and morbidity after a pulmonary endarterectomy is related to pulmonary failure due to reperfusion pulmonary edema. It's very similar to what we'll sometimes see after lung transplantation. But interestingly, we don't see it all that often these days. Multi-organ system failure really means that we have chosen unwisely, and these are patients that really probably should not have undergone operation, but undergone BPA. Some of these patients, particularly the ones I used to see in the United States, would come with hepatic and renal failure because the diagnosis had been missed for so long, and really just terribly adversely remodeled right ventricles. Right ventricular failure due to persistent pulmonary hypertension, also that's pretty unusual these days, but we do get persistent pulmonary hypertension. I'll come to that in a minute, but having a right ventricle fail after a pulmonary endarterectomy would be incredibly unusual. One thing we all worry about is getting a pulmonary hemorrhage. That is, you've perforated the pulmonary artery and have not recognised it. Now, I've never seen this. So I can't claim responsibility for this. This is an autopsy specimen given to me by a friend of mine who does these in another country, and he perforated the pulmonary artery right there where that probe is and didn't recognise it. So you take the cross clamp off and the patient essentially exsanguinates out of the endotracheal tube. There is a way of dealing with this. You've got to be prepared to do it. That is, put the patient on heparinless ECMO and then put down bronchial blockers, and they tell me that it will stop, but it's not really something that you want to see. So we've got some really good information recently from Papworth because they've got tremendous follow-up, much better than UCSD, which sort of has led the way in this, but the way the American system's organised, they don't have the long-term follow-up that they can do in the UK. So we really got some good information, and we should be very grateful for what they've done. So this is survival after pulmonary endarterectomy. Just note here, suppression of 0 on the vertical axis. So by 10 years after the operation, about 75% of patients are surviving, and that's, compared to the natural history of the disease, that's really outstanding. And this is the cumulative incidence of various causes of death. So all-cause mortality is on the red line. So by 10 years, that's about 18% of the causes of death. Unrelated is in the blue dotted lines. CTEPH direct, that's about, at 10 years, that's about 7%. And that would be, for example, right ventricular failure, and indirect, such as an anticoagulant-related hemorrhage, is much lower. Now, the issue of persistent pulmonary hypertension is important because by 10 years, about 50% of patients are still going to have a PA pressure over 25, mean PA pressure over 25. So it is a problem, and really highlights the fact that this is a dual process disease, not only the large vessels, but also the microvasculature. So the trigger for starting pulmonary vasodilator drugs after a pulmonary endarterectomy is a mean PA pressure of over 30. So this is the cumulative incidence of initiating pulmonary vasodilator therapy. So by 16 years after the operation, about 30% of patients have restarted or started for the first time pulmonary vasodilator therapy. So when do you make the decision, though, to start pulmonary vasodilator therapy? Is it straight after the operation, before the patient leaves the hospital? Well, we've got good data from that, on that. So this is the mean PA pressure on day 1 in the intensive care unit. plotted against mean PA pressure at 3 to 6 months, and there's really no association, and the same for PVR. So the answer is not immediately after the operation or before the patient goes home. But what about 3 to 6 months versus 12 months? And now you can see there is a relationship. So you would not make any decision to start pulmonary vasodilator drugs till about 3 to 6, at least 6 months after the operation. So CTEPH is an under-recognised entity which carries a poor prognosis, and it generally takes about 4 visits to a general practitioner and 4 visits to a specialist before the diagnosis is made, and that process can take years. The treatment of choice for patients with operable CTEPH is a pulmonary endarterectomy. In experienced hands, the operative mortality is low, and in experienced hands, that's about 2 to 3%. 50% of patients have some degree of residual pulmonary hypertension, and early intervention is desirable. That is, an early pulmonary endarterectomy before pulmonary vascular and right ventricular remodeling occurs. And there's a new condition now called CTED, chronic thromboembolic disease, which is CTEPH without resting pulmonary hypertension, which is sort of CTED on the way to CTEPH. And we're now recognising this condition. These patients will have pulmonary hypertension on exercise, and now we're so good at doing this operation, that should be considered in patients with CTED before they develop all the downstream consequences of CTEPH. Thanks very much.